Hello, I'm giving a video. You can see the topo and plain axial study of the chest in mediastinal and lung windows. He is a 65-year-old man with history of progressive dyspnea for the past few weeks. You can go through the video. I'll give you a clue that this patient had been treated by a cardiologist for many months and then referred to the pulmonologist due to the unresponsiveness after conservative management which was given by the cardiologist. Does this give any information? He had also been admitted in another hospital some 1 year back due to some life-threatening heart problem. Then many months later came as an outpatient to the cardiologist now and treated for the past few months. I'll also give another clue. At the initial period after echo, our cardiologist had advised him to undergo a surgical procedure, but the patient had refused. I'll also give the coronal images in mediastinal and lung windows. What are all the findings in this study? You can think about the differential diagnosis. If you want more time, you can pause the video and go back to reassess the study. Are you ready? Let's go. Even on visual assessment, we can see significant cardiomegaly due to extensive calcification of the aortic valve with post-stenotic dilatation of the ascending aorta. That you can see it very well, especially in the coronal reconstruction. In the lungs, there is diffuse multifocal patchy ground glass attenuation in bilateral lungs, predominant in the lower lobes. In addition, interlobular septal thickening is also seen with subpleural reticular strands in the posterior basal lungs bilaterally. You can see traction bronchiectasis in the involved lungs. All the findings are consistent with non-specific interstitial pneumonia. Yes, all the findings are very much consistent with non-specific interstitial pneumonia. That echo had revealed findings of typical critical aortic stenosis. So that's why so much of calcification with post-stenotic dilatation of the aorta, ascending aorta. So now the probable diagnosis is critical aortic stenosis with non-specific interstitial pneumonia. Additional history: the patient had undergone management with amiodarone intravenously as an emergency 1 year back and continued orally for few days and then discharged from another hospital with advice of coming back after 10 days. But the patient had taken this for many months without consulting the cardiologist. Now this present cardiologist stopped it just few months back, and even after that, with this history, he has progressed to have dyspnea. So with this history, it's crucial for us to reassess our diagnosis with the history of amiodarone treatment for few months. I'm giving the picture of the recent radiographic article about the amiodarone involving the lung, giving the lung injury. Similar pattern is also supported with the recent radiopedia group. So the amiodarone lung injury can be divided this way. You can see that. First one is chronic interstitial pneumonia, which is the most common pattern, which can be subclassified as 1. Usual interstitial pneumonia, or 2. Non-specific interstitial pneumonia. Usual interstitial pneumonia is irreversible, but many times NSIP, non-specific interstitial pneumonia, can be partially reversible. Now we'll go to the second one, which is less common, giving subacute to chronic type of centrilobular pattern or sarcoid pattern of lung damage with or without ground glass opacities. So that's another less common group. Now the third one is rare with acute presentation, as in acute interstitial pneumonia with or without hemorrhage. That acute interstitial pneumonia, which can be also called as diffuse alveolar damage, as you can see either in late stage of acute eosinophilic pneumonia or like adult respiratory distress syndrome, ARDS. And at this time, don't forget the diffuse COVID pneumonic pattern in both the lungs diffusely. Our CT findings are consistent with non-specific interstitial pneumonia. Are there any subtypes for NSIP? Yes, there are 2 or 3 types. More common is this fibrotic type with interlobular septal thickening and traction bronchiectasis, as in our case. And the less common one is cellular type of NSIP with ground glass opacities with reticulation relatively sparing the subpleural lines. The cellular type is relatively reversible and responds to steroids. The third one, some people talk about the mixer type of fibrotic types with ground glass pattern. So the final diagnosis in our case is critical aortic stenosis with evidence of amiodarone-induced fibrotic mixer type of non-specific interstitial pneumonia. This has been given as quiz. Few of them have given about the calcific aortic valve and many of them described about the lung pathology. But the superstar of this quiz who has knocked both is Dr. Kadir Baksh, and the others had given either NSIP or aortic stenosis. I congratulate all. Thank you everyone who had given the answers. It's my pleasure to thank all the consultants and non-radiology residents for their efforts. Take care and bye-bye.